I am honored to present the first speaker of this morning session, Professor Kumwenda. He is a consultant nephrologist and clinical director in the Renal and Diabetes Care Lanclyde Hospital in Denshire in the UK. Professor Kumwenda, please.
Thank you, Chairpersons. Thank you to Professor Ines and faculty for inviting me to give this talk and share with you some of my thoughts in this excellent Congress, which is, as usual, extremely successful and very educating. It's been a great pleasure to be here. So I'm going to talk about structured education and going a little bit beyond what actually the education does, and looking at some of the benefits, some of the evidence that actually it does make a difference. We'll talk initially with the epidemiology challenges. I will try and define what I think structured education is for patients, types of structured education, and share with you one or two studies showing cost effectiveness and the outcomes of putting these patients through the program. Epidemiology always frightens me, and this is a report from the WHO that came out on diabetes, and you can see the graph there at the top showing a doubling of the prevalence of diabetes related to income of the populations. In red will be the lower the higher incomes, and in blue at the top are the lower income populations. So huge problems across the world, and the regions, obviously, the Middle East and Mediterranean are leading the league tables in terms of trends over the last few years from 1980 to 2014. And the WHO have themselves come up with some recommendations to the countries as to what they should be doing. And I was very disappointed that the only recommendation they've got on prevention and control diabetes to just say, halt the trends. I mean, what kind of pressure is that to the countries? Halt the trend. I don't think that's good enough. We need more than that. We need more powerful messages from institutions like the WHO to start making a difference. We've come through a very interesting period where we've shown with many trials now, the landmark trials, that glycemic control is achievable in the range and in the targets that we should be aiming for. The problem is to translate the findings in studies to real-world experience. And more recently, we've seen that, in fact, the achievement of target HbA1c is going down instead of going up. And this is a study recently published in August 2017 to look at why this gap does exist. Why is the trials, why are the trials achieving better than we are? And I don't want to spend too much time on the actual study, but what they've demonstrated through this is that, in fact, there is probably an issue with compliance of these new drugs by the patients. And so compliance and adherence is short. And so we need to start sorting that out. And without proper education, proper support and follow-up of these patients, then we are not going to improve the compliance, which will eventually translate into, obviously, long-term complications. Recently, we know from the American data that they have seen, again, a drop in achieving HbA1c under 7%, which was around 56.8% in 2003, 2008, but is now fallen to around 50%. And again, it's been highlighted in the medical press that, in fact, this is related to poor compliance from patients. So, is there hope? I think there is, actually. I think one way is to not only give these patients medications, but to empower them. So they take the responsibility themselves. They understand their condition. They understand the reason for the medications that you are giving them. The advice you're giving them to modify lifestyle is to make them feel responsible for themselves. But patients are patients. We are all humans. To actually maintain and sustain good practice, it needs a lot of support from us, from institutions, and therefore structured education gives us that option for treating patients. And here is an excellent example. This is a paper published in the Lancet by Dr. Lin, which is ironically a very interesting surname considering the study. And they looked at patients with type 2 diabetes to see if they could use some education and follow-up, modify their life to see if they could lose weight over time. So these were patients with diabetes for 6 years, aged between 20 and 65, BMI of 27 to 45. And the endpoint was weight loss of more than 15 kilograms and remission, i.e. cure of diabetes, achieving HbA1c below 6.5%. There are 149 patients in each arm, and they concentrated very much on dietary modification. They took all the patients off the anti-diabetes drugs and antihypertensives, and then they put them on this low-calorie diet and followed them up over 12 months. And you can see on the graphs there, the percentage of patients achieving weight loss of more than 15 kilograms was 24% in the intervention arm compared to none in the non-intervention arm. And same thing with diabetes remission, 48%, and drug discontinuation completely in 74% of the patients. And the weight, the HbA1c reduction, again, was more significant in the intervention. So these are doable things, provided you support the patients and you give them the right education as to what to do. So what is structured education? This is a quality assured training that provides people with diabetes and carers and family knowledge and confidence of self-management. And in that, they will get all the information about diabetes, about diet, physical activity, and on medications, and hopefully medication adherence. And they get support throughout the time that they're with the clinic. And this eventually will improve health outcomes and onset of serious health complications. And in the UK, we have these 3 programs. There's one for type 1 called Dose Adjusted for Normal Eating, Daphne, and then Experts in type 2, or Desmond, Diabetic Education and Self-Management for Ongoing and Newly Diagnosed Diabetes. And NICE guidelines, NICE is a National Institute of Clinical Excellency. They are an institution for us that lays down standards and recommendations of what we should be doing in healthcare. And they've given out guidelines of what structural education should look like, should be evidence-based, should suit the needs of the patient, and so on. Support materials, there should be a curriculum, and it should be delivered by accredited and trained educators. And then you should audit the outcomes and not just deliver the program. I'm going to talk more about Expert because this is the one that we use in my institution, and that's also got national data. So they collect data from the units that are doing the program. And there are 4 modules, one on prevention, the other one on general diabetes education program, and then insulin for mostly type 1, and then a weight reduction module. And patients can do one or the other, but we recommend that as soon as they're diagnosed, they should be doing the diabetes module. And then if they want to learn all this and become a real expert, then it takes a full 7 weeks to do. whereas the modules takes 3 days for each one. And the contents for the diabetes program is to describe what diabetes is, food management, what the food they go and buy in supermarkets, to make sure they understand the food labels, tell them about complication and the prevention and the benefits of doing the program. And then there's a questionnaire that they can fill in to visually make sure that they've understood what they've been taught. In the US, they also have structured education programs, and I've given you a reference which has a summary of the national standards for diabetes self-management, education, and support. And I would imagine that there will be other structured education programs in other countries too. I haven't had a chance to find out what there is in Egypt, but I'm sure there is a program. And this is what the expert diabetes module looks like. It's been translated into different languages because, of course, the UK now is multilingual. So all patients from most of the countries can have access to the material. And there is a handbook that goes with the course that the patients can have a look at after the course. And then there is a support person identified who can keep track of their progress. They make contact regularly through telephone. And then there's also, you can't do things nowadays without digital methods. So there is digital methods which helps with monitoring functions, text descriptions, reference to the handbook, and then there is quizzes in there that the patient can do intermittently to review how much knowledge they've retained. And then there is also materials that they can look at in terms of videos. And then at the end, if they do the advanced program, they can actually be tested to see how much they've learned. And this is more in terms of trying to engage the patient very well in the whole program that they have learned over the period of time. But I think as long as they do the diabetes program, then I am happy. So how did we do? I mean, this is data that's been collected nationally, and there were, at the time of the data collection, there were 2,195 programs delivered across the UK. And out of those, there was 26,000 patients that had actually taken part. And you can see the percentage of patients that were enrolled that had done one session, one program, or more was 76%, and then those that had gone as far as more than 4 sessions was 80.7%. The target is 95%. There were, nearly equal proportion of the sexes, and these are the ethnic spread that were involved in the program. Majority were predominantly white, 77%, some black, 3.4% blacks, and 15.57% Asian, and so on. And the other smaller proportions of Chinese and mixed other races. And the time from diagnosis is less than 1 year, 20%, which is disappointing. And I think we should be aiming for much higher uptake of the program as soon as the patient is diagnosed. We know this happens in Germany a lot. Less than 5 years was 53%, less than 10 years, 9.8%, and 10 years or more, 16.81%. And you can see the weight reduction. Remember, the target was 15 kilograms or more. Here is the baseline, which is over 90 kilograms, and over 6 months was 87% reduction in weight. And you can see the BMI reduction from 31.3 to 30.9.
Excuse me. Could you get a little closer to the microphone, please?
Yes, sure. Thank you. And then the waist reduction in waist length was from 104.7 average to 101.8 average. These are the fasting blood glucose reduction from 7.7% to 6.7%, and HbA1c 61.1%, 61.1 millimoles per mole, it was reduced to 52.7. And these were some of the reduction in the cardiovascular risk factors. So you can see blood pressure, diastolic, systolic, cholesterol levels. They've all had a trend of reduction over time. After 12 months, the picture was the same. And I think the important point to make here is that there isn't an increase in these parameters over time. So one would assume that this will be maintained over time as the patient is followed up. The Daphne one, this is for type 1, and I won't go through the whole program. It's quite similar to the type 2 one, but more emphasis on insulin titration lessons, particularly related to hypoglycemia, incidental illnesses, travel, and pregnancy, as we had heard from previous speaker. So from these programs, we put through the type 1 diabetics that are going to have pump therapies. And this is just, again, national data looking at how did the pump patients that had gone through Daphne done over time. And this is data that was collected from England, 2016 to 2017. And you can see there that the HbA1c, those that were on the pump were achieving better levels in terms of HbA1c, blood pressure, cholesterol, and meeting all the three targets. I mean, not brilliant, as you can see, but hey, type 1s on pumps are not easy to achieve these levels, but at least this shows a trend for improvement. And you can see HbA1c, again, those that were having pumps had a trend towards reduction in HbA1c. You know, this is what our managers and our policymakers want to see. They want to see that what we do is actually cost effective. And this is a study that was published in the BMJ looking at cost effective of structured education to prevent type 2 diabetes, economical evaluation. 44 general practices were involved, looking at standard care versus those patients that had had 6 hours structured education. And without going into details, there was, over a 3-year period, there was a 3,643 pounds reduction in cost compared to standard care. The threshold for any intervention in the UK is it should not cost more than £20,000 per year, quality added life year over the period of time of the study. It should not be more than 20,000. If it's more than 20,000, then it's not cost effective. So you can see structured education is very, very cheap. And when you translate into reduction in events in the future, one would then see quite clearly how that will save money for the institutions. So in conclusion, ladies and gentlemen, I'm conscious that we are all trying extremely hard, and that's why we're here, to treat our patients so we can at least reach targets, i.e. make sure a lot of our patients, majority of our patients, are within the targets that have been set. But obviously we're getting overwhelmed. The disease is increasing over time, and we are struggling. And I think it will take more than you and me to control this epidemic. But nevertheless, we have now got tools. Not only have we got medications, but I think we got educational programs that we can add as part of the management of type 2 diabetes patient. And I think to improve that adherence of treatment, then we need to put through these patients through a structured education program. And that does actually give us the platform on which we can make a big difference to patients. Because you can do these structured education on a group level and you can actually go through more patients than you would do if you were just seeing the patient in the clinic on a one-to-one basis. Mr. Chairman.